Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and I wanted to talk about a decision I made just recently to give my style of treatment a name. For a long time, I have considered myself just one of many who use motor points and trigger points to get good results for my patients who have pain and mobility issues. And over the course of time, I'm really starting to see that I don't really agree with a large number of my colleagues on some things. And I think there are important things that make how I assess and treat very different, more effective, faster than the sort of, what would we call the sort of standard medical approach, which I believe my colleagues are more in tune with. And so I've decided to call it Functional Acupuncture. And I'm not looking to trademark that name. If somebody else starts to use the name for whatever they're doing, I don't really care. The point of choosing a name is to say, I do have a methodology that I feel is unique to me. And most of that has been because of very influential doctors whose work I've studied. There are people who have learned acupuncture, like orthopedic styles of acupuncture, from other acupuncturists. Now, they may have learned something at Helms Institute, which only teaches doctors, but then there are some in my profession who are able to take those courses. They may have learned from in Canada, like neurofunctional acupuncture, which is sort of a later developed approach that came out of the Joseph Wong and Si Chan Gun world. That was also who were also teaching at Helms. But we all draw upon some of the same doctors, which is kind of how I felt like I was kind of just one among many. But here's what's different about how I approach things that I'm starting to see. I draw some real distinctions between how I see treatment and assessment, and frankly, why I think my approach is faster, longer lasting, and better. So Vladimir Janda and Carl Levitt, to some degree, from the Prague School of Rehabilitation, were very focused on functional approach to treating musculoskeletal pain. So Vladimir Janda said there's two schools of musculoskeletal pain, functional and structural. Most people have been indoctrinated into a structural approach, which is heavily weighed toward spinal issues, spinal, segmental, nerve root sorts of issues. So unfortunately, many of the patients that I see, I have to sort of deprogram, unbrainwash them, because they've been told that all their pain comes from their back, or all their pain comes from their neck, from their segments, like cervical. I can't, they just say, well, I have this pain and the doctor says I have to have surgery. And that's most of the people around the world. But the genius of Vladimir Janda was that he believed, yes, there are situations where the disc or the spinal segment can make pain worse. And I would totally agree with that. Sensitization of the segments can increase chronic pain symptoms. Absolutely. But what he was saying was it's not the origin of the story. It's typically going to be movement patterns, dysfunctional movement patterns that are going to cause overuse of muscles that are not strong enough, that when their postural muscles are going to shorten and tighten, when they're phasic muscles, they will weaken, and often they're weak because of an antagonist that has tightened, that's a stabilizing tonic muscle. But the shortening of those muscles is going to pull on joints, and that imbalance is what's going to cause the pain. So the functional approach says improve joint function and core stabilization, shoulder stabilization, hip stabilization. Correct the movement patterns, reteach the proper movement patterns, and then the person can live without pain long term. And they don't need palliative every week sorts of treatments. There are plenty of people in my profession who are making tons more money than I am because they're not successful at a long-term treatment. They're good at short-term relief, and the person will take that over lots of medications. So they're going back to their acupuncturist and they feel happy because they're not having as much pain as long as they've got their regular treatment scheduled, you know. My approach is to correct the problem so you don't need to see me until something else happens where you're in pain, and it's usually some other issue. I'm trying to correct the problem, not just palliatively relieve pain. And that's Dr. Janda. Janda was all about improving function, joint function, movement patterns, just getting things firing properly. So you have to think about the whole body and the nervous system, that sensory motor system, which is motor sensory. It's the motor nerves and the sensory nerves. Sensory, not just feeling and touch, but proprioception. Proprioception is so important for how our body stabilizes itself. Most of our stability is coming from a subconscious level that we have learned, and we can learn the wrong pattern. So sometimes we have to relearn that, but you got to fix the problem first. You cannot exercise out of an overuse injury, okay? You cannot exercise out of an overuse injury. The muscle got that tight and is causing joint dysfunction, usually because you're using the muscle. Exercise, possibly, or just normal day-to-day living. You cannot exercise out of an overuse injury. But if you put an acupuncture needle into the motor point of an overused muscle, you can restore the elasticity, restore the blood circulation, get the muscle firing much better. And you can do that with an inhibited muscle too. So that's a functional approach. It's not heavily weighted toward blaming L4-5 in your back for all your back pain. Dr. Stuart McGill also said most low back pain is not due to a disc issue. And if you are at all into research, you know Dr. McGill's work is famous on back pain in the spine. Okay, he did lots of research, and he has methodologies. You probably know the McGill 3 back exercises that are about core strength. He developed a series of simple exercises that people can do to get themselves out of back pain and stay out of back pain. He, like Janda, recognized that muscle imbalances were the biggest cause of back pain. And you can apply that theory to almost everything else. If you're talking shoulder pain, neck pain, foot and leg issues, knee pain, etc. If you think about how the body works, and so here's where I would probably differ in my treatment for certain things. Yes, somebody else from the structural approach that treats the joint itself, that treats the pain itself, that blames the spine, very often are going to get good results for certain things where it was kind of simple. It's the complicated patterns where you really have to have the functional approach. There are a lot of young people for whom you can release a couple muscles and then they're fine. Older people have instabilities we need to consider that do not flare, they do not show up to you as a source of pain. One of the most common ones you're going to see in low back pain is tight lats on an older person that is affecting their hip and their low back. Working on things that are not stable can keep people out of pain. The quadratus lumborum very often is getting tight as a compensation for pelvic stabilization that's not happening on the opposite side. So if you have weak abductors on the right, then your QL may tighten to keep your pelvis straight while you walk. And so then you have this chronic tension in the QL that eventually turns into trigger points and permanent shortening of the QL. Could even cause a functional leg length discrepancy because your abduction is weak on one side. So then you can imagine how that changes the way you walk. And then if I fix those muscles, you may still walk funny. You have to relearn because your subconscious needs to learn a new way to move, the correct way. But it's a functional approach. It's not at all blaming the back. So when I say it's not blaming the back, it's not blaming the spine. It's not blaming the nerves that come out of L4, 5, L3, 4, 5, 2, 3, 4, 5, however your doctor has laid it out for you. So I'm calling what I do functional acupuncture. It is more looking at, and I wanted to mention all the doctors that are so important. Dr. Joseph Wong, of course, is the pioneer who started using motor points of the muscle instead of just Chinese acupuncture points. There are plenty of people in our world who still prefer to use Chinese acupuncture names, and they'll just tell you there's an adjustment to the location, but they prefer to use a Chinese acupuncture name and meridian and whatever. And that's fine, but I like to just be clear about what I'm doing, and I'm treating the motor point of a muscle. And the Dr. Sichan Gun was very big on trigger points and spinal segments. So he would absolutely disagree with me because he thought everything came from the spine. But, he had his say, and he did some interesting research. And when it comes to trigger point pain referral and spinal segmental sensitization, his work is relevant. So, there are things that I've talked about in the past about trigger points and spinal segments getting sensitized. Absolutely. That's not most of your patients, though. That's not most people, okay? That's your tough cases. We're talking most, and that's what Dr. Janda was saying. That's what Dr. McGill was saying. Most musculoskeletal pain, joint pain, back pain, neck pain is not actually because of the disc. And I know that's not what you were told by your doctor. And that's why so many of our fellow humans are suffering with chronic pain unnecessarily. And I don't know how you feel about this murder of an insurance CEO recently. I personally think it's abhorrent. But what I will say is it got a lot of conversation going about how insurance works and how we treat pain or don't treat pain, or we deny treatment for pain, or we just overdo surgery. We just have surgeries out the wazoo for pain. If I ever have an issue with my spine, that is causing me muscular weakness, I want surgery to take pressure off the motor nerve so that I will not be permanently disabled. If I have a disc issue that the doctors are telling me is the source of my pain, and it's not a radiculopathy, it is not a nerve pathway that feels like shock and burning, something that is clearly radicular, I will opt to not have surgery. And in that radiculopathy, I would probably first try some prednisone or something just to decrease inflammation around there. I'd also try acupuncture to try to free up those multifidus muscles around the sensory nerve. Those are in the dorsal side of the spine. So why are people getting surgery for pain? Tell me that. If they don't have a motor nerve compressed that's going to cause disability, how is a surgery that fuses your spine going to relieve pain, which is dorsal, which is on the dorsal side? If you have the people who have sciatica from an L5S1 or S12 compression that is causing a drop foot, those people need surgery ASAP. If you know somebody with sciatica and they're telling you their leg is weak, get them to the emergency room ASAP. The ones who didn't go are the ones that I'm treating for a drop foot and neuropathies. So you do need a surgery for those situations. 95% or more of people with sciatica, I'm going to tell you right now, it is not likely surgery necessary. If we're talking sensory, we're talking numbness, tingling, that does not require surgery. If you think functionally, you're going to realize that most sciatica, high percentages, if it's a true compression of the sciatic nerve, comes from the deep gluteals, the deep rotators, piriformis, the gemelli, obturator internus, the quadratus femoris. The sciatic pathway needs to be considered when you have sciatica, especially when it's something like it hurts, or it's more symptomatic when they're seated, or when they bend forward, or just standing a long time. When those gluteals, the glute max starts to fatigue, and those deep rotators get tighter. You got to think functionally. Stop blaming the spine for everything. You're missing things because you're just treating the spine like a doctor would, and they're failing, or this person wouldn't be in your office. So I have an example for you of where a functional treatment is the winning solution. And this, for me, I see it every single day, almost every patient, but I see a lot of chronic pain patients, So one of my senior patients brought her friend, who's a senior, probably about 70, happens to be a retired medical professional as well, active in her some charitable organization where she's the president. She's a very physically active person in her retirement. She is not a disabled senior, okay? Physically active. She fell last year and broke her shoulder. And then in the process of that recovery, her left hip became painful. And then it became debilitating. And she really couldn't stand or walk. And I saw her for the first time a few weeks ago. I may have mentioned it in the podcast, but I saw her for her first visit a few weeks ago, and she could barely stand. She had a cane, which is not normal for her. And her friend and I helped her to get on the treatment table on her side with the left side up because it was her left side. She said she had nerve pain and aching that went down the entire leg, back, side, and front. And her doctor said there's nothing he can do for her because they've already fused her spine. She has a spinal, like her whole lumbar is pretty much fused, I think 3, 4, 5. And there was really nothing they were willing to do for her. She has some other medical complications that made certain other procedures not a good option. So her friend brought her, and I think I told you this, but I don't like to dry needle on the first visit, but I chose to because of how much excruciating pain she was in, how debilitating the pain was. And after dry needle, I treated, and then I had her stand, and then all the sciatica started coming back. So I decided, okay, I'm going to dry needle, and this is going to be rough for her for several days, but it's better than what she's dealing with. So I dry needled the gluteus medius in several locations and the piriformis. Yeah, I remember I was telling you about how there's different levels. This is that patient. So I saw her, and then she messaged me to give me an update to say that her sciatica was gone, but she still had a hard time walking. It felt weak, and she had pain when she walked. By the time I saw her for her second visit, which was this week, she said the sciatica is gone, and while I'm walking, I'm pain-free. But when I'm standing still, I have pain into the side of the hip, like around the TFL. And then she says like it's a boring ache down the front of the leg. So, and this is where, Janet Travella's work comes in, knowing those pain referral patterns. So so I decided no dry needling today. We're just going to clear inflammation and get these muscles firing better. And something told me to check for a superior gluteal nerve entrapment, because she shouldn't be that weak for only having this excruciating pain for a couple months. So I palpated right above the piriformis, right at that ilium at the top of the pelvis area, and it was very painful there. So I thought, okay, maybe I can free up that area and get better results when I treat the other abductors. So I treated. Oh, and while she's on her side, while she said she didn't think she'd be able to lie face down. She'd had a really bad acupuncture experience in the past where she had like a panic attack and she didn't really want to do face down. And it wasn't with me, by the way, that treatment. She was a long time ago. She was getting regular, like traditional acupuncture. But so she was on her side. I treated TFL, glute min, glute med, piriformis, glute max, stim for up to 10 minutes, got everything moving really nicely. I put a needle right where that I believe that entrapment was, right above piriformis near the ilium, kind of sunk it pretty deep, just to see if we could free up the muscle fibers around that nerve to improve the results. That was also, electric stim for, the whole period, 10 minutes or whatever. Then I had her lie on her back so I could treat her quads, her vastus lateralis, her rectus femoris. I released her psoas on both sides because we're thinking, why are these deep rotators getting so tight? I'm thinking anterior pelvic tilt. That's the functional approach. No needles were placed in L4 or 5 or any of the lumbar segments. And she had said she was having low back pain on the right side. So I had her turn over and I treated the gluteus medius for a few minutes on the right side. And then it was time to test and see where it landed. And she sat up and she said, no more back pain. So that was great. No more back pain. And then we had her come off the table and stand. She stood statically to see if the pain was going to come back, because that's when it would hit, and seemed good. And so then she was starting to walk around. We gave her cane just in case. And she said, it's feeling pretty good, feeling better, no pain. And then, we scheduled a follow up and did all that sort of stuff. And I let her change clothes because I put her in shorts, and it's the winter here in Buffalo, and she's not wearing shorts. So she changed with her friend, and they were talking. And then once she walked out of my treatment room into, like, on the way out to the front room before leaving, she did a little like run in place sort of thing. She said, oh, it feels so good. So I know she's doing very, very well. And I didn't treat the spine. And the doctors were pretty sure that's what it was. But from a functional approach, we have to think about other things. We have to think about pain patterns. We have to think about nerve pathways. Where are the nerves possibly being entrapped and irritated? What about trigger points? What about myofascial pain? I believe that she had sciatic nerve entrapment, and I believe she had irritation of the superior gluteal nerve. And I think that boring ache may have been that nerve. So, so interesting, right? But you think about it functionally. I'm trying to help her have stronger hip stability, less of an anterior pelvic tilt, and deactivating any actively painful trigger points, especially the ones that could compress the sciatic nerve when she's standing or sitting. So the approach isn't to put needles in the spine and where it hurts. Most of her leg didn't get treated, but that was where the aching and the pain was. I'm treating where the muscles are entrapping nerves and causing stability issues. I think she's going to be a bit stronger when I see her again. And I'm going to suggest, and we'll keep working on those abductors, but I'm going to suggest that if she's not in pain, that she starts looking into some physical therapy and, some sort of like water aerobics, some sort of lower gravity situation where she can really strengthen with less fear of her not yet strong core causing compensation that might lead to pain. Because it's going to take a little time for her core to strengthen as well. She's been pretty much unable to do her normal stuff for months because the shoulder and then because of this. So yeah, core will become an important thing. But the difference between a functional treatment and a more structural treatment is the focus isn't so hyper focused on the segment or putting needles where it hurts. And the people who are treating the spine for something like that might get some neuromodulation of the nerve pathway, and they may calm it down, and they'll tell themselves that's the answer. But what they might be doing is just neuromodulating, and then the pain's going to come back. And so they've got that patient for once or twice a week for maybe 10 weeks or something like that till they can start to feel better. Because randomly they are going to hit some of the same muscles. But if they're not thinking about it functionally, it's going to take them longer. It's going to cost the patient a whole lot more money. And then she's debilitated for a couple more months. Whereas if you're thinking functionally, you can get really fast, good results for even somebody that the doctors had thrown their hands up for. So that's the functional approach. And of course, there's way more to it that I've talked about in some podcast episodes that I teach in my courses. Of course, I go into way more detail on these things when I'm teaching a course, but I just wanted to kind of put it out there that I'm starting to say I own my style. It's Janda and Levitt. It's myofascial slings from Andrew Vlaming. It is myofascial pain and pain referral patterns from Janet Travell. It is peripheral nerve entrapments, Andrea Trescott. All these amazing doctors who have put out what I consider groundbreaking work to help people with pain who are pretty much ignored because of the structural mafia, who are going to keep telling you that you got to just put more cortisone in that joint and do epidurals until it's time to do a joint replacement or time to do a surgery and fuse your spine. And then you can come see me because you're still in pain. I think it's a bit of a scandal. And like I said, I think it's important to imagine being a vigilante and going after somebody who's in charge of an insurance company. That's not going to fix anything. But the conversation around it, I think, is worth having. And I hope that we are going forward, going to start looking for ways to solve pain and not hide it. We can't keep medicating for musculoskeletal issues. You are not going to take enough ibuprofen to correct a joint dysfunction, a movement dysfunction. You can't, there's no pill for that. And until we realize that correcting movement patterns is how we get people out of pain, then we're all just doing the same thing. If we're acupuncturists and we're just still sticking needles in the joint and trying to neuromodulate, you're basically doing the same thing the doctors are doing, but you're not using cortisone. And the relief is temporary if you're not thinking functionally. And functionally means not just fix the joint, but think about, why did that joint overwork? What core stability is not happening? Is it pelvic stability? Is it breathing? Is it core strength? Is it shoulder girdle? Is it a combination of those things? The lower cross syndrome, the upper cross syndrome? What is the movement pattern that led to that problem? Because you want to fix that too, so that once you've relieved the pain, which is usually, in my opinion, the easiest thing for me, I want it to stay better. And that's the harder part, because if you're not thinking functionally, you don't really have any ideas about what to do, because someone just taught you how to muscle test for the knee and the hip, and then you thought that was it. And it might not be that. So I'll put it out there. You're going to see me talking about functional acupuncture now. You're going to hear me talking about it. I'm willing to own that I have studied the best, and my results show it. And people can be contrarian if they want, go for it. But I'm only saying this and doing what I do because I don't like accepting that so many people are in chronic pain. To me, it's just, it's absurd. And it doesn't have to happen. So, I guess I don't want to get mad, but that's the end. That's the point. So I hope you all had great holidays, and I will talk to you soon.